Good day again. I hope you've all been able to watch some of the videos and start thinking about some of the questions that you'd like to discuss during our upcoming live sessions. During this talk, I'll give you an overview of the clinical trials of treatments for drug-resistant TB. These are trials that are either underway or about to launch or recently completed. There will also be a few slides at the end of the presentation on trials of treatments for drug-susceptible TB or so-called pan-TB, that is TB irrespective of resistance pattern, and on preventive therapy studies. But in the interest of time, I'm not going to discuss these. I do invite you to look at these extra slides as well as the references we've assembled in preparing this talk. The references include the records on clinical trial registries, which will mostly be in the lower right-hand corner of each slide. There are journal articles in some cases. Sometimes these are results. Sometimes there are protocol papers, and we also include if there have been recent talks at conferences over the last year. We'll also try to include as many of these resources as possible in a SharePoint file that you can all access to learn more about each study. Special thanks to Gustavo Velasquez, a co-I on the trials, who created a foundation for this talk a couple of years ago on which we've built, and Ali LaHood, who diligently combed through all the aforementioned resources and helped me update the talk for today. So the challenge of this landscape talk is always how best to organize it. You can see there are 15 trials represented here. It could be by drug or regimens that they include, by their status, whether they're completed or still recruiting, or by some other organizing principle. This time I've chosen to organize by important questions represented by a series of overlapping circles in a Venn diagram. You'll see. So first characteristic, nearly all of the trials that we'll talk are shortening regimens, which is a super exciting development in drug-resistant TB treatment. A substantial majority are also all oral, having eliminated the injectable. A little more differentiation appears in the next attribute. So for these four inside the dark blue circle are all testing regimens containing pretomanid and the nitroimidazole developed by the TB Alliance. Excuse me. Inside the blue circle, they're all regimens containing bedaquiline, linezolid, and pretomanid, which is the nitroimidazole developed by the TB Alliance. For others, Xenex, BPAL, NTBQ, and NTB are also optimizing doses of linezolid for safety and efficacy. This next circle focusing on quinolone-resistant TB, you can see that NTBQ is the only, is the only trial that's fully within the quinolone-resistant TB circles, indicating that it is the only trial that is exclusively enrolling patients with quinolone resistance. There are many others that include patients with quinolone resistance and also those perhaps with injectable resistance or with treatment non-responsive or treatment intolerant TB. And then another subgroup down here in this gray circle is those that are using sequencing, either whole genome or next generation sequencing to guide treatment decisions. And then lastly, one trial, the TB Trust trial, is using DST on pyrazinamide to guide treatment decisions. The idea being to avoid pyrazinamide's toxicity if the isolate isn't sensitive. It is an exciting time to see progress being made on so many different important questions. So I'm going to start with the all oral generally speaking, the all oral shortened category, some of which are those that optimize the linezolid dose as well. Starting with the next TB trial, which has recently completed and been reported at several meetings this year. It was a randomized controlled trial that compared an all oral shortened regimen, what some call the modified shortened regimen with bedaquiline, linezolid, and other first and second line drugs to the standard of care in South Africa. Note that this is a changing standard of care. They were not randomized to one or the other of these standards of care. Rather, they were used sequentially in South Africa, with the 18-month regimen having been used between December of 2014 and September of 2016. And then the shorter regimen was introduced as the single standard of care. Of note, the experimental regimen used 600 milligrams of linezolid daily, and it was not one of those that actually was optimizing the linezolid dose. It's just something that's going to come up a lot, so I wanted to mention it. Sorry. The efficacy results in the next trial are summarized on this slide. You can see that there were, of the 111 patients who had been randomized, 18 were excluded from the modified intent to treat population, either because they had some exclusion criterion that was detected later, or they did not receive a protocol conforming regimen. Of those 93, you can see that the 44 were randomized to the standard of care and 49 to the intervention regimen. And in the standard of care, outcomes were very poor, with less than a quarter having had favorable outcomes and just over half in the intervention arm having had favorable outcomes. While this does translate into apparent advantage for the intervention arm, these are both worrying results. There's a lot of information in the reasons for the unfavorable outcomes in this study, and looking at more closely at the per protocol group, which excluded from the MITT population 6 who had been lost to follow-up. You can see that this twofold difference still roughly holds. I did have a bit of a question, because I wouldn't expect there to be more favorable outcomes in the per protocol than in the MITT population. Normally, this is a subset. The per protocol is a subset of the MITT, and the same definitions for favorable outcomes are used, but the message is still roughly the same between the two analyses. But what's notable here is you can see that 41.8% of the per protocol population in the standard of care arm had unfavorable outcomes because of toxicity, and 18% in the intervention arm had that same toxicity, precluding assignment of a favorable outcome. And when you look at other unfavorable outcomes, such as death and treatment failure or relapse, they're very similar between the two arms. So while this overall difference is quite important, it seems to not hold when it's really about differences that might be directly related to the efficacy of the treatment, and toxicity is driving a lot of this. Just drilling down a little bit further on the toxicity outcomes, again, you can see that discontinuation due to adverse events was really an important factor in both arms in the study, though more important in the standard of care arm. It's noteworthy that both of these regimens used many of the so-called old drugs, which are known to have important toxicity and tolerability issues. I also just want to make the point that the comparator, and I'm going to go back to that slide, I should have made this point sooner. While this comparator did evolve over time, neither of them is the current comparator in South Africa the current standard of care in South Africa, which actually does look a lot like this experimental regimen, except that it's the 9-month version of it. So the results from this trial, it's really hard to infer anything about how a 6-month version of this regimen will compare to a 9-month version of the regimen. And we know that even the 6-month version of this regimen had important toxicity consequences and also had fairly modest favorable outcomes. The next trial I'm going to talk about is the STREAM 2 trial. This may be the one that's most familiar to you, as we've been hearing about STREAM 1 for some time, and are eagerly awaiting the results of this confirmatory phase 3 trial, which was done to meet conditions of both the US FDA and the EMA for the approval of bedaquiline. So this trial compares 2 shorter regimens, one all oral, notably without linezolid, to the so-called Bangladesh regimen. Enrollment was completed in early 2020, and according to clinicaltrials.gov, we can expect the results in August of 22, reporting on the primary favorable outcome, the primary endpoint of favorable outcome at week 76. Beat Tuberculosis is a pragmatic open label randomized trial that compares a 6-month all oral regimen containing bedaquiline, clofazimine, delamanid, linezolid, and levofloxacin to the standard of care, the current standard of care regimen in South Africa, which is this 9-month regimen. It includes patients who have quinolone susceptible TB, as well as patients who have quinolone resistant TB. And that is the reason that the levo and clofazimine are both noted in red. For patients who have levofloxacin resistant TB or quinolone resistant TB, they receive the clofazimine containing the levo will be discontinued and the clofazimine will be retained, and vice versa for those who have quinolone susceptible TB. And the same practice occurs in the standard of care. There's some exciting features to this trial, including that they are including children over the age of 5 years old, and also including women who are pregnant at the time of screening. The trial is currently estimated for completion in March of 2023. The MDR END study is another open label phase 3 trial, which you actually heard about last time we gave this talk. We don't really have any updates on this talk, despite the record saying that estimated completion was in June of 2021. But you can see this is the experimental regimen, this 9 to 12 month delamanid and linezolid containing regimen that's compared to the local 20-month standard of care. The dramatic trial is actually a new trial that has not yet begun enrolling. It's likely to start at the end of this year. It is a phase 2 trial, whereas most of the trials we've discussed so far are phase 3. And it is an open label, uncontrolled trial that is novel in that it is using this duration randomization approach. So think like a dose escalation study. And the objective is not so much to test the efficacy of this combination against a control, hence the lack of a control, but really to try to model and estimate the optimal duration of that regimen, and it will be estimated both within risk strata using radiographic and bacillary burden as characteristics to determine the risk strata, and between those risk strata. This could actually be a nice follow-up on the NTB trial if, for example, our NTB regimen 4 is found to be non-inferior at 9 months. It could provide some information about whether that regimen could be shortened further. I do acknowledge that the dramatic experimental regimen does not include pyrazinamide, a fact which could have implications on optimal duration. And of course, the NTB trial, with which you're all familiar, fits into this category of trials that are all oral shortened and trying to optimize the linezolid dose. Our approach to the linezolid dose optimization is this dose reduction randomization at 16 weeks or earlier if there is dose limiting toxicity. And as you all know, we have now completed enrollment and expect to complete the trial in April of 2023. Pardon me for not having updated that recruiting word. The next group of trials I'm going to talk about are the all oral shortened pratomanid containing trials, some of which also optimize the linezolid dose. So these are the BPAL in India and Xenex trials that optimize linezolid dose, and the NIX-TB and TB Practical that do not, and NTB. Yeah, sorry. The NIX-TB trial, you likely have heard about it previously. I'm not going to go into any detail, but I just wanted to remind you of this seminal work on the bedaquiline, pratomanid, and linezolid containing regimens on which the other studies build. NIX was a single-arm study that tested the regimen containing those 3 drugs with linezolid used at 1,200 milligrams daily. Originally, it had been 600 milligrams BID, and the treatment lasted 6 months, and the study population was patients with a treatment intolerant and treatment non-responsive rifampin-resistant and multi-drug resistant TB or XDR or pre-XDR TB. The primary efficacy results you can see here were very encouraging, including in the roughly 2/3 that had XDR. Those results were robust in the per protocol analysis and also when the recently presented 24-month follow-up. Again, I remind you there was no control here, so there's no comparison to an internal control. This is merely what could be reported in the cohort that received this regimen. Safety, the toxicity was really noteworthy, particularly among the HIV positive populations and among those that got the linezolid dose 600 milligrams twice daily, and then even pretty important among those who got 1,200 milligrams once daily. And this is what led to the change from the 600 to the twice daily to the 1,200 once daily, and also then to the Xenex trial, which I'm going to talk about next. So Xenex follows still using the BPAL regimen, but examining 4 different dosing strategies for linezolid. There are two 1,200 milligram daily strategies, one for 6 months, the other just for the first 2 months of treatment, and then also the 2 600 milligram daily arms, again, one for 6 months and the other only for 2 months. This approach arose out of mouse evidence that the benefits of linezolid might be primarily realized in the first weeks or months, the clinical data that show that severe toxicity due to linezolid typically appears after several weeks or months of linezolid exposure, and PK toxicity data suggesting that trough concentrations actually drive toxicity, which was the motivation for the once daily strategy, and in some cases an intermittent strategy. The Xenex results have recently been presented and they're summarized here. the efficacy results that were demonstrated in the next study seem to be sustained, and the safety profile seems to have improved. There is no statistically significant difference among the arms. The authors report, or the investigators report, that the trial was not powered to detect a statistically significant difference in efficacy among arms. So it's impossible to really know whether one of these is better than the other. You can see at least a quantitative suggestion that giving linezolid 600 milligrams for only 9 weeks may not be as efficacious as for longer durations or higher doses. And you can also see that it may result in less toxicity, but these are not, we can't draw this statistical inference. TB Practical, really exciting. It's the latest to report. It was a phase 2/3 combined multi-arm, multi-stage study. It was also open label in a non-inferiority design. The stage 1 of the MAMS looked at 3 experimental bedaquiline, pratomanid, and linezolid containing arms. And the idea was to use the results at 8 weeks on culture conversion to select at least 2 experimental arms to move to stage 2. The stage 1 results are here. You can see that the proportion culture converting in the 4-drug regimens appears higher than the proportion converting in the BPAL regimen. This is lower than previously reported by in the NIX and Xenix trials, but all 3 arms did actually exceed the criteria for moving forward to stage 2 of this trial, but really just due to logistical and operational considerations. Only this regimen moved forward against the local standard of care consistent with WHO guidance. And just a note, the reality of long enrollment means that this standard of care changed and went from being an injectable containing 20-month regimen to an all-oral regimen, in some cases, an all-oral shortened regimen. The trial was ended early after an unplanned interim analysis, and the DSMB recommended its discontinuation, noting that further results were not likely to change the conclusions. And so when 152 patients had been randomized to the control and 151 patients randomized to the BPALM regimen, the trial recruitment stopped. And about half of those patients were eligible for analysis at the time of the interim analysis. You can see there were 66 in the control arm and 62 in the experimental arm, respectively, in the MITT interim analysis, and slightly fewer in the per protocol analysis, as they excluded patients who had not received protocol conforming treatment, that is, who got less than 80% of their doses in 120% of the duration of the treatment. And this figure shows that in both the per protocol and the MITT analysis, that the BPALM regimen was non-inferior to the standard of care. This is the non-inferiority margin, and this bound of the confidence interval does not overlap with that margin. So that's how non-inferiority can be established. And even in the MITT analysis, superiority is established for the BPALM regimen. Subgroup analyses have to be interpreted with great caution because they were very small, too small to be conclusive, but they're just worth noting and watching. In particular, the well, can't see the HIV negative bar. Sorry about that. It's somewhere over here. You can see that in the HIV positive group, it is conceivable that this regimen might not have the same benefits that it does in the HIV negative group, and that these differences between groups may also hold by country, and that's likely because South Africa contains the bulk of the HIV positive patients in the trial. So these will be things just to pay attention to moving forward, and it may be that this regimen does hold great promise for certain subgroups, but not all. And I did also just want to note, sorry, on the early discontinuation figures, the protocol defined that early discontinuation should be that the treatment regimen should be discontinued among patients who experienced certain safety events. So an ECG, QT interval of greater than 500 milliseconds, any hearing loss, or if treatment was temporarily suspended for at least 2 weeks, then their participation in the study should be discontinued. And you can see that this occurred disproportionately in the control regimen. So in this sense, sort of similar to what we saw in the next trial, except that in the experimental regimen, there was very little early discontinuation, whereas in the experimental regimen in the next trial, we also saw a lot of toxicity-related unfavorable outcomes there. Little more on the safety in TB Practicale, just kind of supporting the previous comment that the safety profile is certainly more encouraging for this regimen, with about 20% having had grade 3 or higher adverse events or serious adverse events by week 72, and 25% by week 108. The distribution of the adverse events is a little bit different between the two arms, with more hepatotoxicity, more QT prolongations, more renal toxicity in the standard of care arm. The next regimen, the next trial that addresses a BPAL containing regimen, and this one also tries to optimize the linezolid dose, is a newly launched trial in India comparing the same 3 drugs, but with different doses of linezolid. And notably, when there's a 300 milligram dose of linezolid, the treatment is extended to 9 months. These results are expected in sometime in 2024. Now moving on to the all oral shortened regimens for quinolone-resistant TB, and I'm including both NTB-Q and Beat TB in this category. NTB-Q, again, you're all very familiar with. It retains this same linezolid dose reduction strategy as NTB, and exclusively enrolls people with quinolone-resistant, rifampin-resistant, or MDR-TB. Beat TB just recently reported on partial results. I don't have an estimated completion date for the full trial. It examined in a single arm uncontrolled trial a 4-drug regimen containing bedaquiline, delamanid, linezolid, and clofazimine, where linezolid was delivered at 600 milligrams daily. And treatment could be extended from 6 to 9 months if the 16-week culture was positive. These provisional results were just reported at the Union Conference. Of 167 patients enrolled in the study, in 44, the results were not yet available. They considered 123 as the population available for analysis. In that, about 10% were excluded. And you can see that favorable outcomes, this is at the end of the 6 month of treatment, so without any follow-up, have been reported in 100 or 89% of the of the 112 who were eligible for outcome assessment. Like we've seen previously, the toxicity-driven unfavorable outcomes are the most common reasons, although it's a smaller ratio than in some of the other studies so far. And this is just a snapshot on some of the toxicity. You can see there was quite a bit of linazolid toxicity with the 600 milligram dose, and reducing it to 300 milligrams daily at sometime between 12 and 24 weeks seemed to improve the safety profile, and only 3 of these patients required permanent discontinuation. Abnormal QT was reported in 26. The definition of abnormal QT was not provided, but you can see that only 3 patients had a QT interval of greater than 470 milliseconds and none greater than 500, and 2 were permanently discontinued from study treatment because of a prolonged QT interval. This last group of 3 studies is on those which were testing or are testing sequencing strategies to guide treatment change, or PZA resistance to guide treatment change. So this GRACE TB study is a trial in multi-center trial in China that is comparing injectable containing amikacin containing regimens. There are 2 randomizations. The first is before there is any sequencing information, and it randomizes 3 to 1 to the whole genome sequencing guided strategy, the next generation sequencing guided strategy, with only a quarter of the patients going to the active comparator, the 24-month regimen. And then there's a second randomization when the sequencing results are available, and for patients who are designated as having simple MDR, that is MDR susceptible to quinolones and pyrazinamide and the injectable, they get randomized 1-to-1 to these 2 strategies. It's basically a 4-month version and a 6-month version of the same regimen. And then for the so-called complicated MDR, they get changes that include either adding clofazimine, linazolid, or ethambutol, and the details of how that decision is made are not included in the clinicaltrials.gov record. And the primary outcome will be assessed at 18 months after the end of treatment, which we infer to mean 27 months after the 9-month treatment, and after initiation of the 9-month treatment, and 42 months after initiation of the comparator. The INDEX trial is running in a single center in South Africa, and it's using whole genome sequencing to guide the development of a regimen, of the experimental regimen of unspecified length. And it is being compared to the local standard of care in South Africa. At the time the protocol was developed, this was the longer standard of care. I'm not sure what standard of care they're using yet. There are no recent updates on this. The estimated completion is in July of next year. And then the very last trial is the TB Trust trial. It's another trial occurring in China in multiple centers, including patients with fluoroquinolone and injectable sensitive TB, rifampin resistant or MDR TB. It is recruiting, it is open label, non-inferiority trial, and it focuses on the role of pyrazinamide. So the prior to having results on pyrazinamide resistance, the patients are randomized to either get the standard of care, the same one that we saw, this is now a shorter standard of care. It's not the same one that we saw in GRACE, but an injectable containing standard of care. or to get an all oral regimen that notably does not include any of the newer drugs, no bedaquiline, no delamanid, no pretomanid. Then among those who are randomized to this pyrazinamide resistance guided treatment strategy, when their PZA resistance results are returned, if they're sensitive, PZA is retained and clofazimine is discontinued. If they're pyrazinamide resistant, then the PZA is removed and the clofazimine is continued. There haven't been any reports on results yet for this trial, and its estimated completion is late next year. So that is the full list of trials that I wanted to talk about now. As mentioned, there will be some extra slides for you to browse through at your leisure on drug-susceptible TB treatment, as well as preventive therapy studies. And I welcome your questions and topics for discussion. On 22nd of November, the 2 slots are at 7:45 a.m. and 16:15 Central European time. Lorenzo will likely be with you for this session, and I'll join for this one. And these are just some thoughts on ideas that you might be interested in discussing, but I welcome your own questions. Thank you so much for your attention, and I look forward to speaking with you all.